Hi there, how are you? Thank you so much for joining us today. My name is Brian Weed from CHI Health. Thank you so much for joining us today. I am here with three of our top cardiologists from CHI Health. Hopefully, another will be joining us very soon. He is running late with patients, of course. But I would like to introduce you to Dr. Khalid. Dr. Khalid is here. He's a general cardiologist. Dr. Smer, also a general cardiologist. And also Dr. Jain, general cardiologist as well. And these three physicians, they represent a lot of geography here at CHI Health, including the Lincoln area, Omaha area, and many other places that I know you all go to. Dr. Khalid, can we start with you? Would you mind introducing yourself and tell us what you do?
So my name is Adnan Khalid. In addition to general cardiology, I also do heart failure. I'm a heart failure specialist, and I also do interventional cardiology. So mainly I want to touch base a little bit on heart failure. We have done some advances in heart failure. Recently, there has been a new medication called Entresto, and that has revolutionized the world of systolic heart failure, what we call as heart failure with a low heart function. So it's a new medication where we are very actively prescribing it in Lincoln Center, and one of our physicians is also talking to the community about it. So that's one of the things. The other thing is there's a new heart pump out there. It's called HeartMate 3. It's like one of the pumps that we use for advanced heart failure patients. When the medication stops working, then we do that HeartMate 3 pump. This pump has shown very good results. It has very low rate of strokes, and not so much strokes, but the clot in the pump is almost down to zero. Whereas the previous pumps had a lot of issues with blood clots and stuff. So we also do it in Lincoln, and we've been very successful doing that. So we're very excited. We're moving forward in the heart failure arena. One last thing that I want to touch is for patients who have a heart attack, the minutes mean muscle at that time. So normally they recommend that we open the artery within 90 minutes of a heart attack. Here in Lincoln, we do that a lot faster than that. We do it in less than 45 minutes. That's our average door to balloon time. So we're making it better. We're working on making the interventional cardiology field, the heart failure field. We're at the cutting edge of that, and we'll continue to work on it. Thank you.
Excellent. Very good. Thank you so much for sharing that. Dr. Smer, would you introduce yourself and
Absolutely.
let us know?
My name is Smer. I'm a general cardiologist in the Omaha area. I also do outreach in Denison and Harlan sites. My job as a general cardiologist, take care of patients with heart disease, valve disease, muscles, and heart attack as well. Today I'm going to talk about atrial fibrillation, which is the most common heart rhythm problem in the United States. You're talking about the American Heart Association data showed that 5 million people in the United States have atrial fibrillation. So 1 in 5 patients, older than 40, they would have Afib in their lifetime. Afib is considered the leading cause of stroke. And so that's our job as a cardiologist, to make sure that our patients don't end up with a stroke. We normally prescribe a blood thinner to prevent stroke. And the recent advance in this field, that there's a device called Watchman device, which is basically there's a chamber or a pouch inside the heart chamber, the left atrium, that we believe like a 95% of those blood clot, they form there and they cause a stroke. So for people who cannot take blood thinner, or they have bleeding problem with the blood thinner, we can do this procedure. It's minimally invasive. We go to the groin through the catheter, and we deploy this device inside the left atrial appendage, that's pouch, to prevent stroke. The patient has to stay on blood thinner for a short period of time, a month and a half, and after that, we just keep on the aspirin. This device would decrease the risk of stroke to 0.5%. So it's a very important development in the field of cardiology to prevent stroke in those patients. Therefore, a very common heart rhythm problem. I'm sure one of you have heard, or they know some of friends or family about the atrial fibrillation or Afib.
Mm-hmm. Excellent. Very good. Thank you. Appreciate that. Dr. Jain, would you please introduce yourself and let us know what is new?
My name is Anuj Jain. I'm a general cardiologist, also a heart failure specialist, and also do cardiac imaging. Today I will talk about valvular heart disease. Like you probably heard, mitral valve disease, mitral regurgitation, aortic valve disease like aortic stenosis. Traditionally, the treatment of these illnesses has been surgery, open heart surgery to replace the valve surgically or repair it. In the last 5 years, and the technology has advanced, we can repair or replace these valves percutaneously, means without cracking the chest. We can go from the groin. We can replace the aortic valve. We call transcatheter aortic valve replacement, or TAVR. It has been around for 5 years, and we have done more than 500 of these cases at Nebraska Heart Institute, and we have been very successful in doing it. Also, the newer technology which was approved by FDA last year is called Mitral Clip. This procedure is done for mitral regurgitation. So traditionally, the mitral valve is either replaced surgically or repaired, where surgeon goes through the chest partially or opening the chest from the sternum to repair it. But with this newer technology, we are able to repair the valve. There's a small clip. We can go from the groin, make a tiny hole from the right side of the heart to the left side of the heart, putting a catheter through there and put a little clip. And that can improve symptoms of mitral regurgitation significantly. This is also being performed in Nebraska Heart Institute, and we have performed in quite a few patients successfully. Thank
Wonderful. Thank you, Dr. Jain. That's very helpful. Good to know. Questions have started coming in, but I would like to invite our audience to please go ahead and submit your questions now. If you have questions for these cardiologists, we would love to discuss them. A first question has come in, and for any of you really who would like to discuss, Crystal, she asks, is there any sort of preventive screening that can be done for heart disease? Would any of you like to discuss that?
Yeah, I can discuss
Okay,
that.
great.
So basically, the main preventive screening is based on your risk factors and your family history. If you're not having any symptoms, that's always a good sign, not having any chest pain or shortness of breath. But I think one of the tests, if you have a family history or some risk factors, so one of the easy things screening could be a calcium score. You get this CT scan, it takes only 10 minutes or 5 minutes, there's not much radiation involved. We can see if there is any calcium in your heart arteries. And depending on that calcium, we can move forward. And the other thing, the basic screening is always simple. Check your blood pressure, check your cholesterol, your blood glucose should be under good control. You should exercise, and your waist circumference should be, for men it should be less than 40, for women it should be less than 35. So all those things are basic screening. The imaging and all that stuff is the next step.
And I would agree with Dr. Khalid. It's all about your risk factor and adopting healthy lifestyle. That would be the best prevention you can do. Eat healthy, exercise. These are the main thing. If usually people older than 40 doing the calcium score, which is a non-contrast CT scan that will tell us if there's a calcium in the heart artery, then there's heart disease. If anyone experiences any symptoms that for heart disease, like a chest pain, shortness of breath, palpitation, it would be a good idea to check with your family doctor about that. But adopting healthy lifestyle, that's the key to stay healthy and stay away from a heart disease.
Sure. So if maybe you are thinking you have some symptoms that could be heart disease, it could be many other things perhaps as well, go to a family physician, see what the family doctor has to say. If they need to, they can refer to cardiology for additional screening.
Absolutely.
Especially with chest pain, I think that's something very important, because what Dr. Khalid said, minute means muscle. If people have chest pain, that's the common sign of heart attack. It's better to act on that. It's better to be safe than sorry. Check with your doctor, take it seriously, we'll address it. Okay, and there's several reasons for chest pain. Okay, and these are more common than heart attack, but we take a heart attack very seriously.
Excellent. Thank you so much. We have another question that's come in. Sarah, she asks, why does sleep apnea happen? What's the reason behind that? How can I tell if someone I love is suffering from sleep apnea? Do they have symptoms other than snoring that we can know? And is it reversible? What are the alternatives to sleep apnea machines, like the CPAP machines? Those can be kind of cumbersome and interfere with sleep for maybe the other person, perhaps. What are those symptoms?
So sleep apnea is two kinds. Basically, we call it central and obstructive sleep. Central means it's controlled by the brain, and brain does not send a signal for the individual not to breathe. So other is obstructive, where there's a problem for air to travel from your mouth to your lung, which is a more common type, which you hear. And in this sleep apnea patient snores, you may notice the patient stop breathing for a few seconds. Most of these patients have disturbed sleep. They are fatigued during daytime. They can have associated cardiac problems like hypertension, atrial fibrillation. The standard of therapy is CPAP machine. Other alternatives has been tried, like putting a appliance in the mouth by a dentist, or some extreme measures like uvuloplasty, where they take part of the uvula out as a surgical procedure. That has been also tried. Losing weight is the best thing. If somebody can lose weight, that can treat sleep apnea without even need for the CPAP machine.
Yep, no, I totally agree. I think I would like to clarify, there's like most believe that people, they think when they have sleep apnea, it's like they cannot sleep, which is not the case.
Sure.
It's they stop breathing while asleep, and usually their partner, the one would know that. Common side effect, the fatigue, excessive daytime sleeping is very common. When I ask my patient when they watch TV in the evening, they just fall asleep very easily. That's a common sign. Says stop breathing, loud snoring. Weight loss, very, very crucial. At this point of time, CPAP is the main way of therapy. And we know from our field that sleep apnea is associated with a lot of heart disease, like Afib and heart disease. So if you have one of these symptoms, it would be easy to talk with your family doctor. The way to diagnose that is a sleep study. You go to a sleep lab, which is like staying in a hotel room. And what I like about that, usually insurance will pay for that ahead of time. And in the morning, you will have all your answers. Do you have sleep apnea or no? How bad was it? Should you wear a mask or no? And they will try the mask the same night. So you will get all your answers in the morning, okay? And that would help you.
Yep. No, I think that's exactly what they had. Is excessive daytime sleepiness. That's kind of the main thing that gives away. You're always tired, sleeping behind the wheel of the car, or sleeping watching TV. I think look for those things. In addition to snoring and the thick necks are usually also the main issue here. So losing weight would be the best thing, short of CPAP.
And so we know that sleep apnea is obviously a problem for many people, and not breathing in your sleep is a very scary thing. What's the correlation to your heart?
So the theory that when people have sleep apnea, when they stop breathing at night, their oxygen level goes down, and that will cause trouble with the heart, because you're not getting enough oxygen to the heart muscles to electric system. Then when you get into trouble, increase your autonomic nervous system, so you end up with high blood pressure. Afib have very strong correlation with sleep apnea. We think that's the main reason, that high nocturnal hypoxia, that low oxygen level. People who have sleep apnea, they're 10 times more likely to develop Afib.
Wow. So it's kind of a secondary sort of, thing from that other condition.
It's like one thing lead to the other.
Yeah,
Yes.
for sure.
And high pressure in the lungs too, because low oxygen leads to high pressure in the lungs. That also puts stress on the heart, because the heart is pumping blood to the lungs. So high pressure, again, it leads to rhythm problems, most commonly the irregular heart rhythm, but it can also lead to high blood pressure. It just increases a lot of lung and heart abnormalities, the CPAP, the sleep apnea now.
Yeah.
We're realizing that recently. Before 5-10 years ago, nobody even cared about sleep apnea.
Right.
It was just one of the remote diagnoses. Nobody even talked about it. But now we're learning more and more that this is one of the main things, like high cholesterol, high blood pressure. There's sleep apnea that can cause problems with the heart as well.
And since we're talking about advances in cardiology today, I think now there's like a couple of medication under FDA process to get approved for treating sleep apnea. Mainly like kind of relax the airway muscles to help with that. They're still like under research, but we'll see in the next few years if that will take the place of CPAP or no.
Sure.
So, yep.
Very
Stay
interesting.
tuned.
That'll be very interesting to watch. Another question came in, Bridget. She asks, can you discuss and explain the risk factors associated with heart disease and hormone replacement therapies? Is there some sort of correlation between hormone replacement and heart disease that you're aware of? I have not heard that before, but I'm not familiar with this. Is there a correlation somehow?
I can talk about it.
Sure.
So hormone replacement therapy, so there's two, there's males and females. There's testosterone replacement and the female hormone replacement. I think more so than heart disease, there's a direct correlation between hormone replacement, mainly the female hormone replacement, and increased risk of forming blood clots. So there is an increased incidence of maybe forming, clots in your lungs or in your heart, causing a heart attack. So there is a slightly increased correlation. But if somebody really needs it, then they need it. As far as male hormones, testosterone, there's no trials, but again, testosterone also results in, it increases the coagulation or the clotting factors in your blood, and they can result in clot formation in your lungs and in your heart. So there's an FDA warning too that it can result in increased risk of heart attacks. As far as what exactly hormones and what you need to do, whatever hormone replacement therapy, if you need it, then it's good to see your either family doctor or your cardiologist and can assess, what you need. You need to be on aspirin on top of that or some other thing, or maybe some other form of hormone replacement is better for you.
Okay, good to know. Very good. We have another question from Roxanne. She is curious about if she has a stress test, and then that stress test comes back good, everything's fine, blood is flowing. Does that mean she doesn't need to worry about blockages? Or could that be something that's
Imaging guys.
totally separate? Maybe this is a good for imaging, yeah.
So stress test is tells us if you have any significant blockages. You can still have some plaque in your coronary arteries. So if your stress test is normal, it does not mean that you cannot have heart attack, or you should not worry about prevention. Prevention is still very important, but the accuracy of the stress test is about 75 to 80%. So it means more than likely you do not have significant blocked arteries. There are ways to know whether you have mild blockages. Other technology can be used for that, like CT, coronary angiography, or coronary angiography. But in most of the patients, if they are asymptomatic, they are not needed.
But just the fact that you have a normal stress test, that you pass your test, that's a very good sign. That means your risk of developing a heart attack, you're talking about less than 1% in the next 3 or 5 years. So that's a good sign. It does not rule out underlying coronary disease blockages, like what Dr. Jain said, but it tells you that your risk is very, very low. And continue working on your lifestyle pattern, eating healthy. If you have diabetes, make sure your blood sugar under well control. If you have high blood pressure, your blood pressure under well control. And I said, following with your primary doctor. If you have a strong family history of heart disease, maybe more imaging study needed.
Sure.
Okay, but I will look at that as optimistic, as a good sign that you pass your stress test. So I won't worry much about it.
Excellent. Very good. Thank you. We have a question from Mary. She's wondering if you have, can you use, however, minimally invasive surgery to repair abdominal aortic aneurysm? Is that a possibility?
Yes. It depends on the location of the aneurysm. If the aneurysm is below your renal artery, they can be, we call it percutaneously, means without open surgery, they can be repaired. And basically, we go in from the groin and put, we call it stent graft is implanted in your aorta to block the aneurysm. And it can be done relatively easier than open abdominal surgery, and it's a very successful procedure.
Mm-hmm. But just to add to that, but you have to qualify for that. It has to be below the renal arteries. There's something called aneurysm neck, and there are certain characteristics. So a best judge of that could be a vascular surgeon or interventional cardiologist who does this procedure. So you go there, you get a CT scan, and then if you have all those characteristics, yes, it could be done.
Okay. Good to know. Very good. Susie asks a question. What are your thoughts for doing an ablation for Afib rather than just medication and blood thinners?
Yep, that's a good question, Susie. So the way we treat atrial fibrillation, the main thing is the blood thinner. That once you have Afib and your doctor calculate your risk that you need to be on blood thinner, that's the main thing, okay, to prevent stroke. Now, the other way, sometimes patients, they have different kind of Afib. Sometimes they stay all the time in Afib. Sometimes they go back and forth between Afib. One of the options that we offer is Afib ablation, especially when patients are asymptomatic. But something I want you to know, Afib ablation is not cure for Afib. Unfortunately, there's no cure for AFib, but patients who go for AFib ablation, we can keep them in the normal rhythm longer period than just with the medication. So it's very common procedure that we do it in CHI, both in Omaha and Lincoln campus. If the patient taking their medication, they can stay in the normal rhythm longer time, okay, than just with the medication. But having an AFib ablation doesn't mean that you need to stay off the blood thinner. Okay, because once you have AFib, there's always high risk of stroke, and we don't want any of our patients to end up with a stroke. So that answered the question.
Excellent.
Yeah.
We have another question about how can you tell if you have some sort of chest pain? What's the threshold for when you take that seriously? Maybe it's something minor. How do you know if that's a serious condition or something that is not really that serious?
So there are different type of chest pains, but for the heart standpoint, there's a typical chest pain. That chest pain is like it's a pressure-like sensation, somebody sitting on your chest or a squeezing feeling, radiating to your jaw or to your left arm, and then it's relieved with rest and it's exacerbated by exertion. So these are the three characteristics: pressure-like pain, radiating to your jaw or your left arm, brought on by exertion and relieved with rest. If you have all these three features, that's very, very concerning. If you have 2 out of 3 features, it's still good to see a doctor. 1 out of 3, still good to see your family physician or a doctor as well. But if you have none of these features, then probably that chest pain most likely is not your heart. But still, if it's concerning enough, it's bothering you, it's good to always, go see your doctor, at least get an ECG or some basic testing done.
And especially females, they present very atypical, with very atypical symptoms. So they may not have classical symptoms. It's good to go and see a physician if you're having a chest pain.
Right.
And it's easy to ignore. If symptom persist, it's better to be evaluated by your physician.
Right. And just to add to that, diabetic patients, the patients of diabetes, they also have what we call a silent ischemia. They also don't have classic symptoms.
I usually tell my patient, if you have chest pain, call your doctor, call 911, take it seriously, okay? Especially the population we deal with, that are more high risk, older. I think it's always safe to seek the professional advice and go from there. As Dr. Khalid says, there's many reasons for chest pain, but the one we care about most, the life-threatening, is for heart attack. So just take it seriously, call your doctor, 911 if it's severe pain, and we go from there. There's a lot of tests need to be done, evaluation, and go from there. Yeah.
Err on the side of caution in case
Absolutely,
if
be
it's
safe than
nothing, then
sorry.
it's, better safe for sure.
People die
for
from
sure.
heart attack. Yeah.
Absolutely. We have a question. I'm curious. I'm not familiar with this one, but is there a correlation with wisdom teeth extraction and then any heart conditions associated with teeth and cavities and wisdom teeth extractions, or is that anything that? Are you familiar with anything like that?
So I don't think wisdom teeth, I'm not aware of wisdom teeth, but your dental health definitely, has a risk. The poor dental hygiene, poor dental health, they have increased risk of heart disease. I don't know the exact numbers, but so now their recommendations, you not only brush your teeth, but floss your teeth, keep your teeth in good shape and good condition, because there is a correlation between your dental health and your cardiovascular health as well, in short.
Makes sense.
Yep, yeah, I agree.
Overall.
Yeah, there's
I agree. And if you have gingivitis, that puts you at high risk for having heart disease, especially the high risk of infecting the valves of the heart.
Take care of your teeth.
Take care of your teeth.
Go to the dentist.
Yes, if you need your wisdom teeth out, take them out.
Yeah.
That's not a problem.
Don't let them stay if they're causing a problem.
If they're causing a problem, yes.
Sure. Makes sense to me. We have a question from Kathy. She asks, is there something that can be done to increase the thyroid function to improve energy level without causing any fibrillation?
Is there?
So nature has a control system in your body to control your thyroid. So there are hormones which make your thyroid produce certain amount of hormones. If you're over supplementing more than that, you're going to hurt not only your heart but rest of the body. It will change your metabolism. You may feel like you have more energy, but in long run, you can have long-term side effects to rest of your body. So in my medical opinion, I don't think it's the right thing to do to take more than thyroid supplementation than your body needs.
I can't agree more. Yeah,
Mhm.
don't scrub that. Yeah.
Okay.
Right. Because
I can't
I
agree
think
more.
some people that think they can lose weight, and that's true, but it can also hurt you as well. Not only with atrial fibrillation, but causing diarrhea and a lot of other stuff as well. So I think
Cardiomyopathy, heart disease.
cardiomyopathy too. Yes,
Yeah.
exactly.
Okay. Excellent. Very good.
Exactly.
We have a question. So one of the questions from earlier, a little bit different. So we're asking about minimally invasive surgery to repair ascending aortic aneurysm, as opposed to abdominal. I guess that was what the question was asking about, ascending aortic aneurysm.
It's still not available. We can, there's some, for ascending aortic aneurysm, you cannot repair percutaneously. We can do abdominal aortic aneurysm, and there's some centers they do thoracic aortic aneurysm, but that is also very tricky because the blood flow to your spine goes right from there. So there's a risk of having paraplegia. So they're not done in many centers because of the same reason. But at least I'm not aware of any percutaneous repair of ascending aortic
I would
aneurysm.
say at least would be minimally invasive. So like a small incision than a big incision. That's the different technique come from different side. It depends on the aneurysm itself, how big. But in general, at least the standard of care at this point of time in the United States, it's all like open surgery. It's not percutaneously.
And it's up to as Dr. Jain said, it's up to the size of the aneurysm and what surgical techniques they can use. So it could be less invasive, but a surgeon can answer that question better than us based on the anatomy of the aneurysm.
Sure, that makes sense for sure. Just wanted to give our viewers just a note. We have just a couple of more minutes, so if you have any questions, please submit those questions now. We just have a couple more time for a couple more questions that we can move into. Question about fish oil. Will fish oil help protect the heart?
Gonna take that or?
Yeah, I mean, there's some data, they're not strong data, that fish oil associated with the low risk of heart attack and heart disease. I would say if it's not going to help you, it's not going to harm you.
Okay.
I agree
So
100%.
if you like taking it, it's fine. It's over the counter, but there's some data. They're not that strong, but I said that at least there's no harm from taking it.
No harm.
But
Okay.
here's one thing I would advise you caution. If your heart doctor advises you to take a statin because you have heart disease or your high cholesterol level, don't think that fish oil would be a replacement for it.
Sure.
Okay, so if you want to add it as supplement, that should be okay, but not a replacement. Because statin is still the most effective medication for lowering your cholesterol level and preventing heart attack and stroke as well.
Yeah, and some later trials have shown that the fish oil doesn't hurt, but it doesn't help either. So, and it's also a little bit of a blood thinner. So if you're taking aspirin or other blood thinners, then fish oil may slightly increase your risk of bleeding as well.
Good to know. Good to know.
I agree. I mean, one of the trials just published less than 6 months ago, which did not show any benefit.
So the jury may be out.
Jury maybe, yeah. It's more like vitamin C, you know.
Yeah,
We
exactly,
all
yeah.
took it, and now we say we
Sure.
really don't need
It
it.
doesn't hurt, but
Yeah.
okay. We have a question asking about how much blockage, and this may be tough to answer. How much blockage can you have before you need to have a stent?
70%. I mean,
Okay.
70% of the diameter, if it's blocked, then you definitely need a stent or a bypass or whatnot. Before that, you can treat it medically.
Okay. No stent required if it's
Less
less
than
than
70.
Okay. All right. Well, there's the answer to that question. I thought it was going to be a harder one to answer than that.
We like numbers, easy.
Yeah. You have the stats ready to go.
There's a number of there. It's easy answer. Yes.
Why all of the medications after you have a surgery? So if you have a heart surgery of some sort, why so many different medications?
Prevention is the best cure. So if you have a bypass surgery, it's not going to last forever. Every procedure has a durability. So we don't want to see you again for having the surgery again. That's the reason we want to do it. So we want to keep your cholesterol down. So we delay the blockages to come back. There are certain medications like ACE inhibitors. They are known to delay the progression of your coronary artery disease. And if you had a heart attack, beta blockers can help prevent another heart attack. And of course, aspirin also reduces the risk of your heart attack and stroke. So that's the reason we put patients on all these medications for future prevention.
And we also uncover a lot of problems, right? When they come for CABG, we know they have high blood pressure, they probably have diabetes. So a lot of time it happens as well. You get a heart cath and then a bypass. So there are a lot of things that were probably under the radar, now we know about it.
And think about like heart disease, especially blockage, coronary artery disease. It's kind of progressive disease. Like we don't born with heart disease blockages. As we get older, we build up blockage and blockage. So doing the bypass is just taking a different route for the blood to come to your heart to bring oxygen. But there's still a risk that you develop new blockages. So continue with this medication, very, very crucial to prevent further blockage.
Sure.
Exactly.
Okay. I wish that's easy. I wish that's
Sure.
easy. Okay. Yeah, but that's how we would think about it.
Okay.
You want to prevent further another heart attack. You want to prevent further blocks from getting worse and bigger.
Exactly. It's management, it's not a cure.
Absolutely. Yep. Yeah.
Sure. Excellent. As we come to a close here today, I just want to thank everyone for joining us. We have one final question, basically how to get in touch with you all. I know we can go to chihealth.com. You can locate a physician if you need to have a family physician or if you want to make an appointment with one of our cardiologists. Is there a referral required? Do you have to have a primary care physician referral to see you?
Not in Lincoln, Nebraska
Not in
Heart
Lincoln, no.
Institute. So you can call in our number 402-328-3000. Seems like I'm a salesman.
No, how do they get in touch with you, though?
You can
Yeah.
call us directly at this
Yeah.
number, yes. You don't need a referral,
Okay.
at least in Lincoln, and I'm not sure about Omaha.
Yes.
And, we'll be
Okay.
happy to see you. We're still accepting new patients.
Yeah, you can talk with your doctor. They can refer to us, and we have also self-referral
Sure.
both look in Lincoln and Omaha campus.
So you can just directly make an appointment if you need to make an appointment. If you have some questions, you want to meet one-on-one, you're welcome to do that. chihealth.com, you can locate our cardiologists
And we cover different outreaches too, not
Yeah.
just Omaha.
Lots of locations.
Yeah.
you all go from way to like North Platte all the way to like Corning, Iowa, right?
Iowa, yeah.
So lots of geography. And
Absolutely.
again, thank you all so much for joining us. We really appreciate it. So long.
Thank you.
Thank you.
Thank you.